Thanks to everyone for coming back in. My name's Calvin Thigpen. I introduced myself at the start, but I know some people have maybe walked out and then come back in. I'm an associate professor of medicine at the University of Mississippi and associate program director of the internal medicine residency program there. So I'm going to talk a bit about something that we have all experienced, and that is actually it's the simultaneous teaching and care delivery to patients. You've experienced this as a medical student, you've experienced this as a resident, and many of you have experienced it as an attending physician. And each of those things individually, there's a lot of joy to be found in each of them, but when they're done really well together, the joy is amplified. So we've got three big objectives, here they are on the screen, about the environment, the goals of everyone involved, and then some strategies that you can use as the person who is balancing the simultaneous teaching and care delivery. And we'll start with talking about understanding the environment. And I guess the obvious about the environment is first, where are you when you're teaching and delivering care? Are you in the clinic or are you in the hospital? And that is a very, very different thing. In the clinic, you're talking about a very fixed schedule. The patients are coming at a set period of time. You're only going to get a snapshot of them with no real opportunity to go back and see them after that. You've got policies that are in the clinic that you have to deal with that sometimes complicate that with the schedule. We're going to definitely talk about schedule and time in just a little bit. You're also dealing with the learners one at a time. It's usually one person who is coming to sign out to you, the patient that they just saw in the room. Whereas in the hospital, you actually have some latitude with the schedule. The patient is usually there in their room. You can go by the room at the start of rounds or at the end of rounds, or you might choose to go see that patient after rounds or over on your own. You're limited really just by, is the patient going to be out getting some sort of diagnostic procedure or test? There's some pressure to get the patient out of the door, as we all know, but you're dealing usually with all the learners at one time, which can be a great thing and also a very difficult thing too, because they're all on different levels. But this is what it's really about in understanding your environment. It's about the time. And that is, everybody's got a different stake in that. Your patient's time, which is really more critical probably in the clinic. Your patient might have somewhere to go and is getting very antsy about having to wait on you. But also your patient's time in the hospital, and they're going to want your time. Their time with your time there at the same time. Then you're dealing with your learner's time and their obligations to other responsibilities that they might have, your own time, all the other commitments that you have, and trying to balance those while you also devote your own time to your learners. What time of day it is, which is especially important when you're rounding in the hospital and with the other hospital pressures that are there. How many days are you actually going to get to do this when you're in the hospital? And that can vary at some places as little as 7 days to as many as 31 days in a row. And that's a very different thing when you're dealing with a much longer time span and how you decide what you're going to teach, when you're going to teach, and how you're going to teach it. And then who is going to be off and on what day. You have to balance that as well. So time plays a tremendous role in the environment. A few years back, I guess it's been about 5 years now, aware of all those pressures, at our institution we actually conducted a workshop series called Becoming the Superior 2-Hour Teacher. And we did this after hours. We fed everybody and invited the faculty to come, and we talked about each of these 4 topics at different times across 4 months. Because really, that's what we felt like. On rounds in the hospital, you've got 2 hours. That's about how long the attention span of your learners is. That's about how well it fits into the day around their conferences. And you've really got to be able to set expectations. You've got to be able to balance supervision and autonomy. You've got to take them to the bedside. And we're going to talk a lot about the bedside a little bit later. And you have to evaluate them and give them feedback. And we're going to talk about that in the next 2 sessions after mine is doing feedback and evaluation. And we will emphasize more so bedside rounding a little bit later in this talk. In the clinic, it's different. This is really, you've probably seen this in the literature if you have any good or any experience with the medical literature over the past couple of decades when it comes to teaching in certain settings. The concept of the 1-minute preceptor in clinic, and how each of these 5 things you could do in a matter of about 1 minute, which is about really how long you have to teach usually your learner as they finish their sign out to you and as you're about to walk in to see the patient. Getting a commitment being really the most important of these 5 and where it all starts from, and then probing for supporting evidence, teaching some rules, reinforcing what they did right and then correcting some mistakes. And it really does take a lot of skill and practice to get it where you can do it in a timely manner, and your learner feels like that they have learned something from the experience. So all of that is part of the environment. Now, there are lots of other factors about understanding your environment. You have to understand how the interaction is with the nursing staff in your clinic, all the ancillary staff in the hospital, the timeliness with which things get done in the hospital, and so on. There are lots of other factors, but these really are the ones that stand out as the most important about understanding your environment. So a big part of what you do as well is appreciating the goals of everyone who is involved when you're actually teaching and delivering care at the same time. That, of course, starts with the patients. The patients have goals, and you have to definitely understand what their goals are. And often this is the goal: keep breathing. They want to, and a lot of times that is the reason that they came to the hospital, one of many. But what the patient really wants is to get what they came for. And sometimes that's not necessarily a good thing. So for example, the patient might want narcotics. That might be why they came to the hospital. On the flip side, the patient might want to get much better and become much more functional. They might want to resolve their shortness of breath. Of course, they might be disturbed by the fact that they've had GI bleeding and get that resolved. But they also want to be treated with respect in the process. And that might be just as important or more important often than getting what they came for. Many times in the hospital, what we tell a lot of our learners and sometimes tell the patients is the hospital isn't really a place to come and get well. It's a place to come and get good enough to go back home or good enough to go somewhere else. And so a lot of times how you treat the patient really is just as important as what they're getting out of it. And your learners need to know on the front end that that's a big part of their learning, is how the patient is getting treated. And it's not always the medical knowledge that you might be teaching or some other component of competencies. So what are your medical students' goals? I think that your medical students would probably not be telling the truth if this wasn't one of their goals. Now, not all institutions grade on an A, B, C, D, F scale anymore. A lot of it is pass-fail, but a lot of your medical students are thinking about their grade and their interaction with you, and that is one of their goals. But they do have other goals, and these are the honest goals. I think if we could really get down to what does the medical student really want, and you've probably seen this before. Most medical students, they just don't want to get embarrassed, and they want to be right, and they are so worried about being right that they won't say anything often if you just put something out there to the group. That sometimes it takes asking them specifically as an individual to answer. And I think a big part of what we do at the outset of our time with our learners, especially with medical students, is getting them comfortable with just making a commitment. It's okay to be wrong right now in this very, very safe environment where you have several layers between you and the patient before something actually happens. And a lot of medical students will definitely want to get, and I highlighted these last three because these are really the three that we want our medical students to walk away from the experience with. And this because we want them to have it, and it's big goals for them. They really do want to get comfortable with the physical exam. That actually stands out usually more in feedback sessions with medical students or at the formative time when you ask them, what would you like to see happen over the last half of this experience? They will very commonly say, I feel really uncomfortable with my physical exam, much more so than talking to the patient. So that's a big part of their goals typically, and that's something to keep in mind, and we'll talk about in a little while. They also want to learn what's really important. They learned this massive, in the first and second year of medical school, this massive formed history and physical exam that included every single question you could possibly imagine. And you know that if they sat down and asked every patient every single question that you can imagine that's on that form, it's really hard to figure out what really matters, because the patient might make a big deal out of something that's not really that important for why they came to the hospital. And then they definitely want to learn how to make decisions. They want to walk away with some understanding of how is it that you came to that decision that you made, what was important, and then how did you use it to actually decide what to do. For your interns and residents, the goals are a little bit different. A couple of them might be actually in common with the medical students. And I think that first goal is really true for the interns. They don't want to make a mistake. A lot of the interns will be just terrified that they're going to do something that's going to hurt the patient. Or they're going to do something wrong that their upper level resident didn't agree with, or that you didn't agree with as the attending. Now, if they don't have that concern, that too is a red flag, right? You really do want them to be concerned about making a mistake, but not be paralyzed by it either. The interns and residents definitely want to be right as well. They want to be right not only because it makes them feel better and makes them look good, but also because they want the medical students to have confidence in their ability to take care of patients and their ability to lead the team. They'll want to appear efficient, even if they don't actually become efficient, because they're very aware in the system that we practice in just how important efficiency can be. Of course, as we know, it doesn't trump everything else, but it is important. So they would like to at least appear efficient. Find out where they're good and find out what they don't like, actually. And I think that if you talk to a resident, they will often tell you that when they're on a rotation. I just don't like nephrology, or they kind of like the idea of ruling things out. All right, I knocked that one off the list. Now I have a better idea of what I'd like to do in the future. But really, we want them, and I think that our residents, almost all of them, interns and residents, truly do want to deliver excellent patient care because they know that's the hallmark of a good physician. And so that's really what the focus should be. Try to get them to focus on that goal. And delivering excellent patient care really just isn't about just the actual patient care delivery, but you should keep in mind as you teach and as you deliver that patient care that really it's about all of the competencies, and these are the 6 competencies of the ACGME. It's really all of those together that actually help you deliver patient care, and not just that one competency with its milestones that are set out underneath it. So that's really a big part of the goals for the interns and residents. Well, what about for you? And this is you assuming that you're the one who is actually doing the simultaneous teaching and care delivery. And you, if some of you in the room are still in training, you actually, if you go on work rounds or on some kind of preparation rounds before attending rounds, you might be both the resident and this person here. But for you, in order to set your goals to begin with, you really need to review how your past performance has been. And we're going to talk about that near the end of this 30 minutes, about how to even know how you did in the past. But for you, you need to go back and actually review what you did before and set some personal goals at the start, and think of your own competency. And sometimes that's even helpful to think of it in terms of those competencies that are given to the residents and the fellows. In each of those 6 areas, where do I stand in each of those? What can I work on? And really thinking about what would I like to hear the residents and the medical students say to me when we sit down and do feedback later on this month? What would I really like to hear them say? That can be very helpful. There's a notebook over here. I know not a lot of us put notebooks in our pockets anymore because we have phones and the phone has a notepad, but it is really helpful for you to know exactly how you did in the past, to keep notes. And not just to keep notes on the patients as you learn about them, but keep notes on your learners, on the residents, on the medical students, and on yourself. What went well, what didn't go well here. This makes the time when you do sit down later on much easier, but also helps you in the future. All right, so we've talked about the environment, and we've talked about the goals of everyone who's involved, but how about the actual strategies? What is it like to what can actually help to teach and deliver patient care at the same time? And it all begins, I think, with knowing yourself and knowing, first of all, how do I react to certain types of situations? And especially when you go to the bedside or when you're in front of the learners and you hear something said, and maybe in the past you had formed some kind of habit around having a certain reaction of blame, maybe. I say that because I think all of us have some degree of that. We hear that something happened, and our first instinct is to say, "Why did they do that? That makes no sense at all." And to know that you have that tendency is very helpful, because then you'll know I've got to guard against that when we go in the room, and I just have to listen and receive and try not to react too much. What triggers your professionalism or potential unprofessional behaviors? Where are you really strong? What are you good at? What can you really teach well? And if you're really good at role modeling difficult conversations with patients, or your strength is in cardiology and you really, really know that subject really well despite the fact that you are a hospitalist, and you feel very comfortable, you need to go to those strengths and make sure that you hit on those strengths, not every single day all the time, but make sure that before each of your learners in their experience, they see you in your comfort zone or really hitting your strengths. And then on the flip side, where are you weak? And in those areas, oftentimes your learners can teach you. One of the most rewarding experiences that I've had as an attending physician was when I was the attending for one of our current hospitalists when he was nearing the end of his second year. He was much more up to date than I was on the literature in hospital medicine. And he was very good. So I told him after we'd been together for about 6 or 7 days, I was like, if you see something on rounds that you think you can teach on that is recent and is up to date, you feel free to jump in and go right ahead. And then of course, if I feel like we need to stop or we need to cut it short, I'll just tailor it and we can move on. But in that way, he taught me quite a lot in an area where I didn't feel quite as strong in, say, some of the recent literature on sepsis, for example. This was shortly after the most recent sepsis guidelines had come out. And then in those areas of weakness too, you have to hold yourself accountable. If you know that you're weak in a certain area, don't just totally avoid that area either. You've got to actually try to do what you can to shore those weak areas up at least some so that you can provide what some of your learners might need because they might also be weak in the same area. This is absolutely crucial. You have just got to be able to listen. And if you aren't good at really focusing on what someone is saying and processing what they're saying as they speak and processing it in the context of someone else there, then you've got to practice this somehow and somewhere. I will admit, personally have this tendency to drift off to the 10 or 11 other things that might be going on today or something that someone might have said to me right before round started, and thinking about that as, say, a student is presenting about a patient that we've been taking care of for 5 or 6 days, and I already have a pretty good idea what we're going to do, because usually in that spiel that the student is going through, there might not be any new medical information, but there's a lot of information to pick up on for evaluating the student later. There are patterns in how they're presenting, information they might be leaving out, perhaps new information that the patient told that person that morning that you didn't know. And at the same time, as you're listening, being able to, and we're going to talk about this in a second too, being able to scan the room. There's lots of information, other information going on in the room that's not necessarily listening, but being very attentive. And I think it just goes without saying, you've got to try your very best to ignore your telephone, and even if that means if you have one of these watches that vibrates, take it off during rounds so that you can actively listen. One thing that your learners will definitely pick up on, your residents and students, is if you deliver expectations at the start, they're waiting on you to deliver on following through on them. So if you deliver the expectations and then you don't follow through, or you just let something go and you have the plan to cover it, they will pick up on that. And it will actually, in some way, it might disappoint them too, even if you did a great job otherwise. So just be prepared when you do deliver expectations to make them such that you feel like you can live up to these things, and then be very intentional about following through. So about 2 years ago, we decided to create a top 10 concepts for every rotation that the residents were going to experience. And so we actually, on general medicine, went so far as to make these boards that now are up in all the team rooms that have the top 10 concepts, and you can take a dry erase marker and check them off as you go. So one thing that is very satisfying, I think, for everybody on the team is to go and check one of those off. But it doesn't always, we tell the attendings you don't have to sit down and do a 20-minute talk about it, just that we cover what we need to know about these important concepts that you need to walk away from this rotation with. And being very intentional about doing that really makes a difference to your learners. So, and then as you're actually walking through and you're going from one patient to the next, and let's say you've got a lot of people to cover, think about different things on, and I'm going to use rounds here as an example, places on rounds that might be wasting time, where there's not a whole lot of value, and try to eliminate those things entirely. So if that means actually going to see 3 or 4 patients or so on your own when rounds are over, great, go do that. If they've been patients who've been there a long time, not much is changing, and really use that time on the patients where you can actually do a lot of valuable teaching. And then as you walk from room to room, if you've noticed, the students and residents are very slow walkers. They're very casual. You might work with fast walkers at your institution, but ours tend to be very slow. Use that time right there too Be thinking about who's going to make the next decision when we get to the next room, and also be thinking about possibly covering some of those patients you know you won't see together as you walk. Get a student or a resident to tell you as you walk about that patient so you're updated. Another strategy is, and we're going to talk really about the patient care and teaching that happens completely simultaneously in the room and in just a minute, but before getting to that, try to do the best you can in letting the learners be the stewards of the information. It is very helpful to go and review the medical record prior to rounds, because you can strategize about what you want to teach on. But you don't have to tell them that you've seen everything. Let them tell you. If they know you've seen everything, you have just short-circuited lots of opportunity to actually evaluate how good they are at collecting data, reporting it back, interpreting data, managing the patient, doing each of those things. So let them be the stewards of the information, and don't spend time on rounds rehashing histories that they took, going through the medical record and double-checking things that they're actually telling you. You can do that after rounds, and if you pick up on where they might be dropping information, that's something that you can adjust rounds the next day and give them feedback on. All right, so being with the patient, and this is the key strategy really to teaching and doing good patient care at the same time, is to actually do it right there in front of the patient. And when I was going through training, we did not do a lot of this, where we actually walked in the room and the student or the resident presented the entire presentation right there in front of the patient with all of us standing around the bed. But I found that this really is the best way, the most time-effective way, and the best way to collect information on everyone in the room, the patient, the presenter, everyone else on the team. And really, the best position to stand is where you can see everybody. Usually the patient's right side, especially if you're right-handed and you like to examine the patient with your right hand coming across, with the presenter on the opposite side and everybody else is standing right here. And you don't even have to tell everybody where to stand. You just walk in the room and go straight to the patient's right side at the head of the bed and stand right there next to the patient. And notice the eye contact that the presenter makes with the patient. How much are they just staring down at their notes? Is the patient making eye contact back? Is there seem to be rapport here? Does it look like they actually saw each other this morning? You can figure that out pretty fast. The patient might even say, I didn't see you this morning. And notice, is everybody paying attention? And if they're not paying attention, make them pay attention. So, and you can make them pay attention by, of course, asking a question about what do you think we should do? Shift the room a little bit over to someone who's not presenting. And you really want to, when you do this, though, make sure that the patient knows who is in the room, because it can be very intimidating if you have a legion of people on your team to walk in the room and the patient's feeling very vulnerable in the bed. So if it's possible to sit down at the level of the patient too, then that's nice. But you want to identify who all is in the room if the patient doesn't know that. And then whenever the presentation is all finished, make sure that we're out of medical lingo and we're actually talking on the patient's terms and they understand what's going on. One thing that is very common when you're doing this, though, is that especially if a student is presenting, is they will get to a point when they're talking about the plan and they will just but we thought we could do this or this. And then there's this fill in the blank. And the expectation is that you will fill in the blank since you're the attending and you'll make the decision. So you definitely want to defer all commitments right back to them. Well, what would you like to do? Or if there's somebody else in the room that you feel like might be better equipped to answer that question, the next level up, what would you like to do? Or if you have a very good upper level resident but you're not sure how prepared your intern is to move up to the next level, ask the intern, what would you like to do in this situation? And then allow, too, if the patient has questions, the learners to answer those questions and fight that tendency to answer yourself, because you can learn so much right there just by watching that about them and the patient. Differences of opinion can be tricky here, too. So let's say the team wants to do something and you know that's just not the right thing to do. Is this the right place to talk about it right here in front of the patient? I think that you have to really lean on the team a little bit to let you know, is this going to be okay for all of us to be in the room at this time? Is there somebody else in the room that the patient doesn't want in the room if we all walk in there? Or how does the patient feel if we talk this all out? Pretty easy to pick up on that after a day or two with a patient, and it might be better actually if just a couple of people walk in with some idea of what the plan will be before you go in. But usually talking out differences of opinion actually builds the patient's faith that lots of people are thinking about me, and this is not just we're doing this and not giving it much thought. And then when a teaching point is actually brought out by you or by someone else, to underscore that without trying to undermine anybody. Because there is a little bit of that at stake, is if you undermine everybody else in the room by saying we're going to do this and not that, the patient has the potential to lose a bit of faith in the rest of the people on the team. So some of these things are indirectly mentioned as well here about the family environment, which we just talked about. It's very important, too, to really have your learners prepared for this. They're not going to be fully prepared until you're actually in the room and do this for the first time, and they will get more comfortable pretty quickly, even those who are usually timid with presentations, but to let them know about what was on the previous slide. It's okay to talk about differences of opinion while we're in the room, or that I'm going to ask you when we get in the room and there comes to this point of indecision, I will likely ask you to make some kind of commitment there. And it's okay if you commit to something that's not quite right. We're all there together. We can adjust as we're in the room. So can't stress enough how much bedside rounding and being there with the patient is the best opportunity to teach and deliver really good patient care at the same time. Because as you're wrapping that time together up and you go back through the plan and where the patient can understand it or the patient says it back to you, usually the patient feels like, all right, now I know what the doctors are doing now. And that's usually one of the scariest feelings for your patients, is that they feel in the dark when they're in the hospital in particular. So, all right, and then lastly, another very important strategy is when this is all over at the end of the day or end of rounds or at the end of clinic, and this is hard to do with every single day or every time you have a clinic session or every time you're with learners, is to actually reflect on what went well, or reflect on your notes that you might have taken, or if you haven't taken them yet, to go ahead and take them right then before you forget about what happened. Take some notes on the patients, the learners, yourself, and the processes that you used during your time together, and then to actually reflect on that and make adjustments. And then also to ask everyone on the team, to ask them, especially the upper level resident, for feedback on how they think it's going, because they're the ones who are talking to everybody else on the team when you're not there after you've walked away, and might be able to give you some more insight. And then if that's not really, you're finding that's not quite helpful enough, chief residents are often quite helpful too, to come along with you on rounds. And I know that that's probably not done too often, but there have been some instances where we've asked a chief resident to join us on rounds just to get a better kind of outside perspective. And yes, that does modify behavior some if someone else comes along on rounds, especially if that person is perceived to have some authority. But it can be helpful. They might pick up on who's not engaged during rounds, what could you do that might be a little bit better, and help you hold up that mirror for yourself. So in summary, the keys to doing simultaneous teaching and care delivery: understand your environment, take the time to understand it before you enter it with your learners, and understand too how it can change and be dynamic. Recognize the goals of everyone involved, no matter what environment it is that you're going into, and then also use some of these strategies, consistently reflect on them, and see how you can improve them, and always be looking out for other potential strategies as well. Any questions? All right.
So if the students or residents are afraid of saying anything wrong, they always want to be right, isn't that magnified by getting them in front of the patients?
It definitely can be, and it usually is, especially right there during those first few days of a time together. So it really does take a lot of encouragement to say, it's okay to go ahead and just make a commitment. And if you make a commitment and it doesn't seem right, you're not going to be the only one making a commitment. Somebody else on the team will also make a commitment, and we'll talk about. And it really does take a little skill to to know how to respond and not have them feel defeated in any way or feel like that they made a mistake. But also, it is important to correct if there's something that they said that would potentially harm the patient or not be good for the patient. So it does take some skill, some practice, and that has been something that's come up in feedback before.
Just getting them to say anything.
And I think that what they have to understand, and one thing that's important for us to teach them, is that our patients need to see us as humans. I mean, we're not, and I think in a way, it encourages the patients to see that we are not. It's not just automatic that we think this is the right thing to do and there's no other way to do it. And I think to tell the students, the residents, that the patient's getting a chance to see that encourages them to contribute some too. And you're right, getting them to say anything is difficult, which is sometimes why you have to be specific and say, John, tell me what would you like to do?